Welcome, everyone. We're delighted to have Dr. Greenlee join us today. Heather is an associate professor in the Cancer Prevention Program and an associate professor in the Clinical Research Division at the Fred Hutch, and also has an associate professorship at University of Washington. She is our director of our Integrative Medicine program here at SCCA and has been offering fantastic services to our breast cancer patients with integrative medicine. And we're really delighted that you accepted our invitation to give us an update on our program here at SCCA. Thanks so much, Heather.
Great. Well, thank you all so much for the opportunity to talk with you. I'm not supposed to be biased towards any one disease group, but I'm completely biased towards working with the breast group. So I love the fact that I get to speak with you all today. My talk is really in two sections. The first section is I'm going to give you an update on where we are with our integrative medicine service and what's happening there. And then I'm actually going to pause it and allow us a little bit of time for a conversation, because I'd really like to get some feedback from all of you about what's working for you, but really if there's anything that's not working and what we can do better in providing our services. And then I'll move into talking about some of the research. I'll spend the rest of the time with the research, give you an update there, and then open it up for some conversation. So we have a vision for integrative medicine here at SCCA. I moved here a little over 4 years ago to help launch our integrative medicine program. And our vision all along is that we will have effective integrative medicine therapies that will be integrated into all aspects of cancer care and will become standard of care. Our focus in our integrative medicine program here is on improving quality of life and increasing resiliency from the time of diagnosis through treatment, survivorship, and the end of life. We actually don't work with patients who are at high risk of developing cancer, not because we're not interested in that, but because we just don't have the clinical bandwidth or staffing to do that right now. In terms of the treatments that we provide, we have an emphasis on acupuncture, mind-body therapies, lifestyle behavioral counseling, and counseling on the appropriate use of dietary supplements. And we are a very highly interdisciplinary group. And we have really these 4 areas that I'm going to walk you through today: clinical care, education, research, and guideline development. Next, please. So what is our service? So we started offering clinical care in January of 2018. We have an integrative nurse practitioner. I see patients as a naturopathic physician, and we have a growing team of acupuncturists. All of our services are fully billable. We have a shared electronic health record, and actually Epic is making our lives easier. So that's been a good change on our end. We are co-located within the SCCA Outpatient Breast Oncology Clinic, which makes it easier for us to interact with some of you on a regular basis, which I think is terrific. And then we use our clinical program as a research platform. Next, please. So this is a picture of some of us. We have actually 2 new people who've just joined, so I don't have their photos yet. Again, I see patients as an ND. Susanna Myers is our nurse practitioner. Kathy Sanders, who some of you might have known, retired over this past summer, and Susanna Myers was working with Dr. Kovler for about 10 years in GI oncology, and she just moved over to us. It turns out she had a history of, or a background in working in massage therapy, and I've actually done a lot of training in integrative medicine, and so we're delighted to be working with her. Jonathan Simon leads our acupuncture team and is also our clinical ops lead in integrative medicine. And then we have a growing group of other acupuncturists as well. We did just hire somebody to start providing acupuncture up at the SCCA Proton Center. And we actually have a position that we're getting ready to post for a naturopath to see patients up at the Proton Center as well. The Proton Center, before they became SCCA, they've actually had a naturopath there who's also an acupuncturist, pretty much providing all of their supportive care services. And so we're changing that model to more closely reflect what we do here at SCCA. And so nutrition's moving up there, and a lot of the other supportive care services are moving up there as well. I'm thrilled to share that we have a nurse on the way. We have not had a nurse and have been suffering greatly for that. On November 1st, Heidi Stecker is going to join us as a nurse, and she's worked in other areas of the clinic as well. And she also has some integrative medicine experience. Hopefully, with Heidi coming on board, we're hoping that she's going to be able to liaise more closely with the medical oncology teams so that patients and their providers will have more seamless care provided alongside integrative medicine. A sad news, our service line manager, we finally got a service line manager a little over a year ago, maybe 2 years ago, and she's leaving to go to a different position outside, and we currently do not have a service line manager. We're also losing our director at the end of this month, and so we're a growing group within supportive care, but we're without a figurehead currently. Okay, next. So it's important to note that integrative medicine functions within the larger SCCA supportive care division. So I don't know what all of you hear or what you know, but I just want to give you a quick overview. Over the past 4 years since integrative medicine started, SCCA has consolidated all of its supportive care services into one division. So we're now a division of supportive care. And so within that, we have integrative medicine, nutrition, PT, spiritual health, social work, psych, palliative care, and pain. And it's actually been a really wonderful process to have us all work together. It's a little discordant sometimes because we have a group of medical directors who all report up one ladder and a group of managers who report up another ladder. But as a group, we're all working, I think, really well together, and we're trying to figure out what we want to look like with the onset of FHCC, because we're very hopeful that we're going to be able to grow our supportive services kind of across the board. I think all of us have room to grow. Next. So one of the great things that's come out of our working together with the other supportive care services that we've formed the dietary supplement working group. As I think you know, and actually especially amongst our breast cancer patients, our patients are using dietary supplements quite a bit. And so we have not had standardized recommendations across SCCA for delivering information to patients, or frankly to providers, about what's safe to do and what's not safe to do. So we've created, a few years ago, we created a new collaboration between integrative medicine, nutrition, and pharmacy. And we created clinical practice guidelines on the use of dietary supplements in SCCA general oncology. And we've now most recently developed standardized clinical pathways to review the dietary supplement treatment interactions as well as safety profiles, and to, for these to be filed as a note within EPIC. So these were just published, back up one slide, go back to the previous slide, thanks. So these were just published within the past couple of months, and they're stored on the SCCA Pharmacy SharePoint site. If you'd like to see those, this is really meant to be a resource for our oncology teams. And so we're actually in the process of getting ready to write this up, and we're in communication with the editors at the Journal of Oncology Practice to see if we can share this with our colleagues nationally as well. But we're really excited about this because we're trying to harmonize first just within our supportive care services what our recommendations are on dietary supplements, and then we'd like to harmonize across our clinical teams as well. There are a lot of different opinions about dietary supplements, and we really want to be making evidence-based recommendations. I can say we actually have a research study we have an admin supplement from the Office of Dietary Supplements at NIH to do some analysis of dietary supplement interactions in a cohort of breast cancer patients out of Kaiser Permanente, California, where we have long-term breast cancer outcomes. And so I'm hoping in the next 6 months, maybe 12 months or so, we'll be able to share some data on whether or not we can see if use of, especially high-dose supplements during treatment affects any long-term outcomes. So stay tuned on that. Next slide, please. So we are involved in a couple of different clinical training programs. You may or may not know that our MedOnc fellows have a supportive care rotation. And so as part of that, they spend a month with us and all of the other supportive care teams. So we actually don't get a lot of hours with them, but they do shadow us in our clinics. They shadow me, they shadow our nurse practitioner, and they shadow our acupuncturist so they can see what that looks like in clinic. They present cases during our case management meetings, and they also have experiential learning opportunities. Then we also have an integrative medicine rotation for APP oncology fellows. And so we feel very strongly that we want to train the next generation of providers and what integrative medicine has to offer. We are in conversations with SCCA about developing an education program for community acupuncturists to train them in oncology, so that we have a group of community-based acupuncturists who we feel we can continue to refer our patients to, but that's something that we've been told needs to be postponed until after the merger. Next slide, please. I think many of you know, but maybe not all of you know, that I am very involved in the development of clinical practice guidelines for integrative medicine, and our whole team is really increasingly getting involved in these. I'm going to talk about some of our projects with ASCO. I'm involved in the NCCN guidelines on pain, and have been working with them to bring up, to make sure the pain guidelines accurately reflect the integrative medicine modalities that are effective at pain management. And then I've been very involved with SIO, and actually Rachel Young and I and some others are working on an up-to-date update for integrative oncology, so for that to be published hopefully in this next year. Next. So these are the guidelines that we published back in 2017 out of the Society for Integrative Oncology on the evidence-based use of integrative therapies during and after breast cancer treatment. Deborah Tripathi at MD Anderson and I co-chaired this out of SIO, and we got some good, we were thrilled that it went to Time and Consumer Reports. It tells us that it got out to a lot of people. Next slide, please. But when I moved here to the Hutch and NSCCA, I started working with Gary Lyman, who was able to help us work with ASCO to for ASCO to endorse these guidelines, which was a really terrific, because then the guidelines were disseminated broadly to a wide group of folks. Next slide. This has led us to a new partnership that we have with ASCO on three new guidelines that are in place going on right now. One is an integrative approach to cancer-related pain management. And the next is screening, assessment, and management of fatigue in adult cancer survivors. And then the last one is an integrative oncology, is focused on integrative oncology care of anxiety and depressive symptoms in adults with cancer. And so these are efforts, two of the guidelines, the pain and anxiety and depression guidelines are being led by SIO, and ASCO has partnered with us on that. The other guideline is being led by ASCO, and we are partnering with ASCO on that. And then there's actually, we anticipate having funding to be able to, from a foundation through SIO, to be able to do three more guidelines on this. So we're really excited about this. Gary Lyman has been a key person to help me work on this with SIO and ASCO. Next. Just to let you know, we're actively we're working on a lot of acupuncture research. We don't have anything open in breast right now, but I wanted to just show you what we have going on in other areas. I'm really interested in taking the work that we did with our breast cancer trial in SWOG S1200 with Don Hirschman, and where that study showed that acupuncture use with aromatase inhibitor-induced arthralgias was effective at decreasing pain. We're thinking about what we can do next with that particular patient population. But the current trials that we have open right now, Stacy Cohen in GI is PI of a study looking at the use of acupuncture in GI oncology patients receiving oxaliplatin-based therapies, and this is with cryotherapy. So we're looking at the combination of acupuncture with cryotherapy. And it's really looking at, it's a feasibility study, but CIPN is really our main outcome there. We have a really interesting study with Sarah Sutka, who's a GU surgeon, and we're looking at bladder cancer patients receiving BCG treatment, and we're testing whether the acupuncture protocol helps patients have better adherence to the BCG installation, and whether or not they can retain the installations longer, and whether or not they can receive the full course of treatment. That trial is enrolling very well, and we're, depending on what we find, we're hoping to be able to then apply, submit something to SWOG to have a multi-site trial there. We're a site in a MSK study that's being funded by PCORI that's in BMT patients. So this is in myeloma and lymphoma patients receiving auto transplants. And because of this trial, we are now giving acupuncture in the inpatient setting over at the within UW Medical Center and our SCCA beds. And so we're really excited about that. That trial, we just opened it and we've already enrolled 8 patients, so it's enrolling really well. This is a trial looking at the use of acupuncture to prevent the use of opioids for pain management. And so this is a really, it's really terrific working with the BMT team. And then we have another trial that is, we're just getting ready to open it up. We hope it's going to open in January. And this is in sarcoma patients after surgery to see whether or not acupuncture can reduce the use of opioids after surgery and help with pain management. So if you have any ideas for acupuncture trials, let me know. We've developed some, I think, really good infrastructure here to be able to conduct this. Our patients love acupuncture. One of the strongest benefits of acupuncture is it's non-pharmacologic, and so we don't have to worry about interactions with therapies that patients are receiving. Okay, next slide. So I just want to end with a couple of resource slides for you. This is just some information on when to refer your patients to integrative medicine. This is a list of what acupuncture is. We found acupuncture to be particularly useful for here at SCCA. So again, aromatase inhibitor, induced arthralgias and musculoskeletal symptoms, fatigue, chemotherapy-induced nausea and vomiting, pain, sleep disorders, and mild anxiety and depression. Acupuncture is useful for all of these. Our current wait list is about 2.5 months. We're hoping that when we have the new building, that we're going to have more space and that we'll be able to then have more acupuncturists be able to provide more acupuncture to our patient population. This is also why we're looking at ways to train up our community acupuncture providers, because we currently can't handle the volume of everybody that we have. For integrative medicine, integrative medicine referrals either to me as a naturopath or to our APP, we do general integrative medicine consults where we just talk. People have lots of ideas about integrative medicine. They're often not fully formed, or they're getting information from a lot of different sources. So we help them figure out what their goals are and then help them make, hopefully informed decisions about how to proceed. We spend a lot of time counseling patients on the appropriate and safe use of dietary supplements. Susanna Myers does a lot of mind-body medicine with her patients, focusing on anxiety, fatigue, sleep, and pain. And then I do a lot of counseling really based on where the research that we're doing on food and nutrition, physical activity, and weight management. So next slide. In terms of other patient resources, I don't know if any of you have had the chance to check out the new patient ed resource page on the SCCA website. They've spent a lot of time putting up PDFs and videos of documents that patients can access directly. I still have a little bit of trouble sometimes finding things, but this is the pathway. You go to home, patients and caregivers, and then patient ed resources. And so we do have some specific PDFs that you can share with your patients if that would be useful. One is an acupuncture referral list. So we have our team has gone through and vetted a list of acupuncturists who I'd say meet certain qualifications out in the community that we are comfortable referring them. Now we usually are not comfortable referring patients with extensive metastatic disease or patients who are really having a lot of difficulties with their treatment, but this is there for you to use. We also have developed a handout that explains how patients can go about finding an acupuncturist in their community. That it really educates the patients and hopefully the acupuncturist. If it takes them, it talks about specific safety parameters, when it is and is not safe, really from immune function perspective to use acupuncture. We also have a statement in there saying that we do not support the use of Chinese herbal medicines during active treatment because we don't really understand the many of the interactions that may take place. We also have a nice handout there on acupressure points for common symptoms. And so this is something in like nausea, fatigue, pain. There's another resource on mind-body relaxation resources that lists different apps and websites and books that people can use. And then we have one on sleep problems and healthy sleep habits that addresses really just a healthy sleep routine and provides some resources for people there. So, so I want to open it up to all of you, and you can come off camera if you want or not. But I'm wondering if anybody has any questions about our integrative medicine service, and also if anybody has any suggestions on how we can serve your patients better. One thing I can say is that we have developed a specific pathway to see breast oncology patients who are experiencing aromatase inhibitor-induced arthralgias. Because those patients are not actively receiving chemotherapy, they can be seen in our acupuncture clinic spaces down in the Arnold Wellness Center. And so we do think that we can get those patients in more quickly because we don't have to see them in clinic. There's patients that can be seen down in the wellness center need to have, I think, an ECOG status of 0 or 1 and need to not be receiving active infusion therapy. So we are trying to see your patients more quickly there. But Hannah and Jen, I see that you came off camera or came on camera.
Heather, we're just so happy that you're here. And I think just having you here makes a difference, but the reality of the care you guys provide is just wonderful. So I don't mean to be asking for more, but wasn't there going to be a massage component?
Yes. So we had a massage therapist for about, I don't remember, 2 months, 3 months, and then she quit. This is early on. And so, and then we decided at that point that having one acupuncturist just was not sufficient, that there's no way that we could have an acupuncture program with one person. So we turned that massage therapy position into an acupuncturist. So we are hopeful. We would love to bring massage back on. We need space. And so right now we don't have any more space to be able to see patients. So that's a problem for us. And the other problem is billing. Many patients would have to pay out of pocket, but we think we can do that. So not everybody has acupuncture covered and they pay for it out of pocket. And so we think we can do the same, but it helps if directors of programs ask for it and not just us. So.
Thanks, Heather. You actually answered part of my question, which number one, we would be thrilled to have massage therapy options. I think our patients ask about that frequently and would be a nice tie-in with physical therapy and things as well. So please, yes, consider that an ask. And then my other question was the little more difficult question about how billing is structured and what that experience is like for patients in terms of coverage and how that's turning out.
Yeah, that's a really good question. So I don't know if, yeah, I see Jonathan Simon is on the call. So Jonathan has been spending a lot of time working with our patient financial services on that. So when patients are referred to us or they self-refer, patients can also self-refer, they go through a check to see what coverage they have, and then they're informed about what coverage they have. There have been some substantial administrative gaps, workflow gaps, and getting that information to patients in a timely way. And so Jonathan has spent many, many hours trying to get that streamlined. But ultimately what happens when patients come at it, when PFS finishes, they tell patients what services are covered by insurance and what services they would have to pay out of pocket. And so one of the reasons that we have for our ND APP services, so my services as a naturopath are not covered by all insurance plans, but everything that our APP does is covered by insurance. And so that's one of our ways that we've made that accessible to patients. She's also just completed training in auricular acupuncture. So though she cannot do full body acupuncture, she can offer, she's getting ready as soon as her credentialing goes through to be able to offer auricular acupuncture to patients. In terms of our acupuncture services, those are covered by some insurance plans, and then patients decide to cover that themselves as well. Jonathan, do you want to add anything there? I think you might, we can't hear you.
Hi everyone.
Oh,
I think you covered the bulk of it. The insurance landscape across integrative medicine, it does present some challenges, but there is a fair amount of coverage for acupuncture, as well as for our APP, and there are just some minutia with the ND coverage and the acupuncture coverage, especially around Medicare for acupuncture, that's been a little more difficult to navigate. They only cover one very specific diagnosis for low back pain, chronic low back pain, not related to cancer care. But in the past few months, especially after Epic, we have been working out, sorting through these workflows with the PFS team, and it seems that approvals are now, that process is working more smoothly.
Jen, I would say, are you hearing on your end that patients are having issues?
I think that it's one of those things where, we're really enthusiastic about making referrals. However, I also, not that I can take on knowing the PFS and knowing the coverage, but it would be nice for us to sort of, as providers, to have some standard language about expectations in terms of the timeline and the coverage, just because I don't want people to be disappointed. And I think, just being able to sort of explain that there's a process and what that looks like might be helpful for all of us that are seeing folks in clinic, and even for our nurses and things when questions come in.
Okay, so we will work on that, and we can push that out through probably Better Together, but we can also come back to this group and just push that out so that you have that language.
Yeah, I mean, just and just even a few bullet points, nothing super, just so that we're setting expectations appropriately. Yep. Would be helpful.
Yep. I mean, so the short answer is that everybody is evaluated to see what's covered and what's not, and then patients are told what they might have to pay for out of pocket. And I will say, we used to do more, I think it was considered charity care, providing integrative medicine services. And somewhere along the line, a couple of years ago, and I know Hannah and I have talked about this extensively, that stopped. So we did not make that decision. That decision was made for us.
And do we know
okay, so two requests. One is that not stop, that's not fair. And we do have to address that there can't be a disparity in that the affluent, well-insured patient gets integrative medicine and the others don't. So that's a note that we have to discuss that, because that was not the original deal. But I not to keep pushing here, but you've hired a physiatrist, which is fantastic. And in terms of what we would like, we'd like a full cancer rehab program.
We're right there with you. Yeah, Hannah O is terrific, and we want that to keep going. We are very hopeful, and I see that Nancy's on this call. We're very hopeful in the with the new FHCC model that, or even I'd say even with or without FHCC, we're really hoping to be able to expand our supportive care services across the board, because there's a lot of patient need still. Does anybody else say
that one of our priorities, team, is the fact that none of these things exist at UW. And so we are trying to think about the system and not simply the cancer care that takes place at the SCCA. And the second, with regard to uncompensated cares, there's an awful lot of regulation that's wrapped around that. So sometimes we have to make decisions that may not feel very good, but are unfortunately in keeping with the regulatory environment.
Yeah, thank you, Nancy, for adding that. I'll say we are looking into a couple of different models of providing these services at lower cost. And I don't think we can do that now with our current space, but when we have new space, we might be able to. So there is a model out in the world that's called community acupuncture, where you have multiple people in the same room. And so it's just, it's more efficient for a provider from a provider standpoint. And we're starting to look also into offering group visits. Susanna and I have a meeting with Andy Pete later this month, or maybe next month, to talk about using group wellness visits with integrative medicine to talk about all of these things simultaneously with a group of people. And then they also get the beneficial sort of supportive care effect. And I'll tell you, if we're going to roll that out, we'll roll that out with breast first, just because we think that your patients will be really excited about it.
Yeah, something like that I think would be great for the supplements. I think that would really lend itself well to a group setting, and all the patients come in with so many questions about herbal supplements. And just I haven't been here very long, but my limited feedback when they, see when I refer them to the nutritionist is, I feel that they want something a little more, more from the integrative standpoint than what a standard nutritionist can provide. And then, to go back to the cost of the acupuncture, I think it'd be helpful if I knew how much patients would have to pay if their insurance didn't pay for it, just so that I can give them an idea whether it's something that they would want to do or not.
So we can certainly do that. I don't even know, and Jonathan doesn't even know what it costs oftentimes, because it really varies based on their plan and based on some other factors as well.
I was just thinking maybe if their plan didn't pay for it at all. I guess from where some of the other states I've practiced, actually, it would be less common for the insurance to pay for it. And most of the patients, if they went to a community acupuncturist, probably cost, $100, $150. And I just wanted to get a feel for ballpark.
For if a patient is doing self-pay, the initial visit is $135, and the follow-up visits are $105. And that's because they were recently adjusted. They're basically adjusted yearly. And so they went up to 135 and 105. That's with self-pay.
Okay, so that sounds fairly competitive with the community, at least the ones I've been in.
Yeah, we've tried to keep it as low as possible so that patients can access it. Thank you, that's really good feedback. One thing I would say is if your patients have specific questions about dietary supplements, send them to an integrative medicine consult instead of a nutrition consult, because we have more time and different training to spend with them too.
I think the other thing I might point out is I haven't looked at the Memorial Sloan Kettering website recently, but the last time I looked, it was pretty upfront about the fact that, this is a self-pay enterprise. And so we are not alone in having to face some of the challenges of trying to think about how to help patients access these services in a world where they're not covered that often. So
yeah, and I'd say where we differ from MSK, Nancy, is that we really, one, they have a $10 million endowment, so that to their integrative medicine program. So they're just in a different ballpark than we are from the get-go. But two, we really have a strong commitment to wanting to work with underserved patient populations, and we have the opportunity to do that. MSK really doesn't do that quite as much. So I would love for us to figure out models for us to be able to serve those patients. And again, Hannah and I've spent a lot of time trying to figure that out. And we, possibly with some philanthropic funding that may or may not come in, maybe that, but we are working on that. We've also thought about developing some training programs for, say, senior acupuncture fellows or something like that, who could come in and provide care as well. And so that might be another way for us to get care to patients. This is really helpful feedback for us, so thank you so much. Any other questions or comments? Okay, so let me move on and start talking about some of the research that we're doing. So next slide, please. So some of you have heard about Cook for Your Life, which is a website that we absorbed here at Fred Hutch about 2 years ago. This is a website that started in New York City. A longtime collaborator of mine there, who I've had some NCI funding with, started a nonprofit called Cook for Your Life, and she started giving in-person classes about nutrition to oncology patients. And then she decided somewhere along the line, after we had an R21 and as our R01 was just getting funded, she decided on her own to launch a website called cookforyourlife.org. And then long story short, I moved to Seattle. Our R01 was still going on using this platform, and then she decided to retire. And so we decided to bring this in-house here to Fred Hutch through wonderful support from the director's office. And we are now transforming this into more of a research platform and for us to do some work here. So the website has 1,100 recipes that are all oncology focused, 400 articles, over 200 videos, and it's really meant to be a resource for patients and their caregivers and their clinicians. So next slide, please. On the website, we have really 3 different paths that are journeys that patients can take or people can take. One focused on cancer prevention, one focus on use of nutrition during treatment to counter some side effects, and one on survivorship. Next slide. And this shows some of the detail that we have on what patients can use during chemotherapy. So we have, these are the 9 most common treatment-related side effects that can be influenced with nutrition. And so this is currently, if you click on those, what happens right now is that you get just a long list of recipes that might be useful for patients to eat. We're actually in the process right now of further developing these different, say for example, low appetite, developing that into a multimedia page where it will have more recipes, more nutrition education, and more resources for patients. And so then we're planning, and then we just submitted a pilot grant to be able to then test that information and test it to see if it actually can document changing patient symptoms. And so again, we would want to test this in probably breast and GI patients. So I'll let all of you know if that in fact gets funded. We may roll it out even if we don't get funding. So that's something that's happening. And just so that you know, we have established a very strong group of medical and scientific advisors for Cook for Your Life, drawing heavily from our Fred Hutch and SCCA and UW faculty and staff. And so Nancy serves on that. Thank you, Nancy. Rachel Young does as well. So does Julie Graylow. And then we've also formed a group of, we call them CONA, Clinical Oncology Nutrition Advisors, that are at our SCCA Oncology Nutrition team, and they're giving us strong input in this. And we are now doing this website in partnership with SCCA. And so we've really brought a very strong clinical presence to the information on the website. Next, please. Oh, here, I did keep this in. Okay, these are all of our wonderful medical and scientific advisors who you will recognize some of them. Okay, next. So where are we in terms of the website? And the reason I'm telling you this is, again, we're wanting to use this as a research platform, but we need to have this up and functional and being a really a functional website that people are going to want to go to. So we currently have about 192,000 monthly unique visitors. I found out recently that we had almost 2.5 million unique visitors in this past year, which I was very excited about. We have a growing number of Spanish users. So the website is fully bilingual in English and in Spanish. Most of our English viewers come from the US, Great Britain, and Canada. Our Spanish viewers come from across the world, Argentina, Mexico, and Spain. We have a social media following. We have about 30,000 regular followers and about 100,000 monthly views. We've put out a weekly newsletter. If you don't subscribe to it, please do, and tell your patients about it, because it's a way just to get some, inspirational information about food and nutrition into people's inboxes. We're partnering with different media groups right now, just so that we can have outlets for the website. We're working with Cancer Health. They put us in their quarterly publication, and we have some more in the pipeline, so stay tuned on that. So next. So what are we doing in terms of research? So the first thing we need to figure out is who's actually using the website. So we can use Google Analytics to look to get demographic, general demographic characteristics of people. But we're developing a new robust analytics program with specific dashboards that allow us to track site usage. We've received really generous funding from AWS, and we're creating a data lake that allows us to pull in all of our data from Google Analytics, plus all of our social media streams, plus some of the other website features that we have, so that we can look at utilization patterns. One thing that we did right away when we launched the website last December is that we just started a cross-sectional study where we asked people to take a really short survey to tell us who they are and why they're on the website and what they're looking for, because Google Analytics won't tell us if they're a patient or a survivor or a caregiver or a clinician, and certainly won't tell us the type of cancer that they have. So we've had a little over 4,000 respondents to date. The vast majority of those are breast cancer survivors. So I thought that this team would think that that's particularly interesting. The platform that we have allows us to do on-site consenting. We're able to collect online data collection from them. And then in return for people filling out this questionnaire, we give them an e-booklet. So this is going to be a platform for us to be able to ask people a lot of different questions going forward. So if any of you have nutrition related questions, we can always fold those into questionnaires that are going out. We're getting ready to analyze, or we're actually actively analyzing these data right now. Are going to submit it for, I think we're submitting it to one of the conferences that abstracts are due in early November. It's either ASPO or AACR. I'm not sure which. Okay, next slide, please. So this is a study that Nancy's the PI of this one. Thank you so much, Nancy, for your support of this. This study is called Cook and Move for Your Life. Some of you have heard of this already. This is a study that's a pilot study that we're just wrapping up right now among breast cancer survivors. Pre-COVID, it started out as being a study where we were recruiting early stage breast cancer patients who were post-treatment, who had good performance status with really no comorbidities, who had access to a smartphone and either had low intake of fruits and vegetables or they had low levels of moderate to vigorous physical activity. And we are going to bring them into a study and randomize them to 2 arms of what we call our low dose, or dose level 1, where they would just have one in-person session. There's a diet and physical activity session, and then receive 6 months of what we called e-health, so texts, newsletters, access to a special website login on the Cook for Your Life website, and a Fitbit to monitor their physical activity. Or they would come in for a more intensive program where they would come in and do 6 monthly 4-hour in-person sessions, and then also have the 6 months of e-health as well. And we are going to use the Human Nutrition Lab down in the Arnold building, convert that kitchen into a teaching kitchen. And so we had really great plans to do that. So in February 2020, we had 27 people enrolled and randomized, and then COVID hit literally right after everything closed down right after we had our first class. So next slide, please. So then we had to transfer one before, go back one. Thank you. So we had to transfer this on, or we had to pivot from our in-person sessions to turn this into a virtually delivered Zoom-based physical activity and nutrition program for cancer survivors. So we did this. So we got a HIPAA compliant Zoom account in conjunction with the director's office. We tested a 1 2-hour online session, bringing in our educators, versus 12 biweekly 2-hour online sessions over a period of 6 months. And what we added on there is that we added, so we had to do all of our data collection remotely. So we figured out there's these devices called Tasso devices that we can mail out, where they would collect blood and it sticks on somebody's arm, and through, it punctures the skin, and then through suction, through vacuum, draws blood. We're able to collect blood from some people. We sent everybody Wi-Fi enabled scales so that we could collect their weight. And also, we were collecting stool samples, and so we were able to collect stool samples through the mail too. So where we are right now is that we are closing data collection the end of this month. We had, of our original 27 people, 10 of those people ended up re-enrolling in the trial, and then we're able to enroll 64 additional patients. These are all from your early stage breast cancer patients. Next slide. I wanted to share with you, I think, some of the remarkable work that really thanks to Michelle Ahrens and Rachel Young, we were able to do with recruitment and retention. So we are able to really, in my opinion, rapidly accrue patients to this study during COVID too. So pre-COVID, we opened up in early 2020, and we did rapid accrual in January and February, and then had to close everything down, and then we opened up again in the fall. So over this period of time, we sent out recruitment letters to 927 of your patients. We screened by phone over 300 of those women, 138 were eligible, and eventually 70 completed all data collection and were randomized into the trial. At 6 months, we have pretty good retention, especially I think given COVID. So we have 73% completed all of their follow-up data collection, 26 partially completed. I think almost everybody gave us information on our main nutrition outcomes, but we had a lot of trouble getting actographs back from people, and also some of the blood and stool samples. And we only had one patient totally drop out of the study. So that, so thank you for having such a highly involved group of patients. Next slide. So we have another study that's coming down the pike, we hope, which is being partly funded by AWS. We're interested in taking the website and developing an Alexa skill to go along with that. We're working with the nutrition team and with Rachel Young to develop this skill so to help patients manage some of their nutrition related side effects or side effects that can be managed with nutrition while they're receiving dose-dense chemotherapy. And so we're in the process of figuring that out. There have been some technical difficulties on that. We had to wait for Alexa to become HIPAA compliant, or we wanted to wait for Alexa to become HIPAA compliant. So we're hopefully moving on that and getting that protocol submitted soon. So again, we'll be recruiting your patients for this as well. Next. So we have a bunch of ideas on where we want to take this platform going forward. We're working on our search engine optimization so that more people can get this information. We're interested in looking at some studies in the future that work on nutrition misinformation. In the oncology setting, we think that we might be able to help fill a gap there. As I think any of you who talk to your patients about what their questions are about nutrition and fad diets and fasting and dietary supplements, there's a lot of room for us to fill in some gaps there in information. We're developing a content contributor program, both from internal and external folks to we really want to develop a more diverse population of voices who are represented on the website. We're developing new videos. We're hoping to eventually develop a section specifically for clinicians and maybe develop some materials on how clinicians might be able to access this kind of information to use with their patients. We have some tools that we want to build. We want to build a meal planner, maybe a chat bot to enhance our user experience. We're in the process of developing some online classes to test, and we're putting in some grants to get funding to do that. And then at some point, we'd like to turn this into an app as well. Next. Okay, so switching gears a little bit, I just want to talk briefly about another ongoing study that is related to breast outcomes that I thought you all might be interested in. And so this is a study, this is an RO, and this is my last study, and then I'll open up for conversation. This is a study that's an RO1 that I'm co-PI on with Marilyn Kwan. She's a cancer epidemiologist down at KPNC in Oakland, and she does a lot of work in breast cancer survivorship. And so we are now in our 5th year of this RO1. And what we're doing here is we're looking at we have NCI has a specific funding mechanism looking at cardiotoxicity in cancer survivors. And so we have the study. So the aim 1 is to examine overall cardiovascular events in women with and without breast cancer in KPNC. We are looking at CVD events in breast cancer based on treatment received, and then also examining CVD events by adherence to CVD medications. And then we got an administrative supplement to look at CVD events by neighborhood, social, and built environment. Next slide. So just to show you, we have a really big multidisciplinary team. After this was funded, we brought in Richard Chang, who's a cardio-oncologist at UW, who's been really terrific. But we have cardiovascular epi represented, cerebrovascular disease. Don Hirschman's a collaborator from the breast oncology side. And then our biostatistician has expertise in causal inference models. And so we've all been learning a lot outside of standard epi analysis methods. Okay, next slide. So these are, we presented our AIM-1 results at ASCO 2020, and I can say our AIM-2 results I'm presenting at San Antonio in December. So those are accepted for poster spotlight presentations. So in AIM-1, we compared the risk of CVD events in women with and without breast cancer, looking at, again, CVD outcomes and CVD risk factors. Next. So this is just a one-slide summary, and we're submitting these manuscripts by early November. We have a revise and resubmit to JCO, so hopefully these will get published. But just very briefly, this is just showing what the rates are of CVD events based on treatment received. So if you look at this on the left, you have the different CVD events, and then you can divide it into the kind of treatment that women received. And then on the right, we have our hazards ratio. So anything to the right of the line is an increased risk, and anything to the left of the line below 1 is a decreased risk. So basically, and not so surprising, is that women with breast cancer who receive chemotherapy more likely than women without breast cancer to develop heart failure, cardiomyopathy, and VTE. Women with breast cancer who receive left-sided radiation were more likely to develop heart failure and VTE. And women who received hormonal therapy were more likely to have a cardiac arrest and to develop VTE. So we think our VTE is new. Our findings there are new. The resubmission that is going into JCO now, they suggested, and it was a good suggestion, to not lump all chemotherapy together. So we're actually teasing that out, and we're looking at specific combinations of chemotherapy. So the paper will have more details. Next slide, please. This paper, this other aim is then looking at CVD risk factors. And so what we found here is that women with breast cancer were more likely to develop hypertension and diabetes compared to women without a history of breast cancer. And also that women with breast cancer who received any treatment were more likely to develop hypertension and diabetes. And so we also think that this is one of the first papers that's really looked at what are some of the long-term CVD risk factors that women develop following a breast cancer diagnosis. So next slide. And that's it. So I just wanted to thank all of you for listening and about what we're doing both in integrative medicine and what my team is doing in terms of our research. I really value all the collaborations with all of you and welcome more. There's a couple other protocols that are sort of in the works right now that we hope will get some funding, but certainly open to any new collaborations, and I'm happy to answer any questions. Thanks.